I think we'll start, so we've got plenty of time. I'm Steve Westling. I'm the CEO of the NHNMRC, and it's a privilege, and I'm pleased that Monash has asked me to come and chair this session because it's a terrific session. They're going to be 10-minute talks with 5 minutes of questions, so people are going to have to get their ideas across pretty quickly. But having looked at the presentation, I mean, it looks like a fabulous meeting with all sorts of exciting talks today. And we're going to have questions from the floor. We won't have a panel, so the questions will follow the 10 minutes. And I'd like you to come up to the microphone to ask the questions because it is being recorded, and if you don't do that, then your question won't be heard. And there is a microphone here for the speakers. If some of the speakers want to wander around like a rock star and use the microphone, they're welcome to do that. And also importantly, before we start, I would like to acknowledge the traditional owners of the land we're on and acknowledge elders past and present and any Aboriginal or Torres Strait Islanders in the room today. So I think we should get going, and Yuming Goh is the first speaker, and Yuming is the Professor of Global Environmental Health and Biostatistics and the head of the Climate Air Quality Research Unit, or the CARE Unit, at Monash University. And Yuming's going to talk to us about modern environmental epidemiology for global environmental and climate health. Thank you very much.
Okay. Thank you, Steve, for your introduction, and thank you everyone for coming. I will give a talk for the modern environmental epidemiology for the global environmental health. Okay, I declare there is no conflict of interest for this presentation. Okay, currently, at this moment, all of us have faced a big problem, that is climate change or environmental change. The first one, that is global warming, heat wave, that is experiencing, very frequently, and also wildfire smoke, or maybe general air pollution, that is another big issue, and also flood, and also tropical cyclone, drought, and also glaciers are melting faster and faster. So if we want to address this problem, we need to understand their health impact, or to give some evidence to the policymakers. So what is the role for the modern environmental epidemiology in this area? The first one, that is to perform the environmental exposure assessment to get the environmental data. And the second one, that is the environmental health risk assessment. And also the third one, that is the environmental scenario assessment to understand the health benefit, health risk in different scenarios. So for the first part, that is new technology and method for the exposure assessment. So what has been used in this area? The first one, that is most popular one, that is remote sensing. Like, we can equip the cameras in the satellite or the drones to take images, across the world, and we can understand what is the wildfire smoke from and where is going to, and we can understand how to mitigate the impact. And also we can use this technology to monitor flooding, drought, and green space and residential environment. And another one, that is GPS and GIS. Currently this is developing very quickly, so we can equip GPS to each person and to understand to track their where they are going, and so we can link the data to each exposure and understand the health impact. And also currently, for example, for the air pollution, there are still limited, air pollution monitors. So we need to increase the monitor stations. So our group just, tried to transfer or convert the traffic cameras to be the air quality monitors to increase, the air quality monitoring, so we can link the data to each person in the future. And also in our group, we try to combine the new technology and a new method to predict air pollution, flooding, and tropical cyclones. For example, for the air pollution prediction, we combine the remote sensing data, meteorological data, land use information data, and elevation data, population density data, and we develop a new machine learning model, combine all of them together, and also we can apply the the chemical transport model together. to predict air pollution, and also we can divide the air pollution into traffic-related, industry-related, and wildfire-related air pollution to understand the health risk. So this is one of the examples. We predicted air pollution across the world from 2000 to 2019. So we can say, just example in 2019, only very small field, like only 0.9% of the global land area, and only 0.001% of the global population had an annual exposure to PM2.5 at concentrations lower than 5 microgram per cubic meter, which is a guideline from WHO. Okay. And also, we can divide the data into wildfire-related, traffic-related. This is just one example from our group. We divided the data into for wildfire smoke. So in general, globally, the wildfire smoke increased from 2000 to 2019, and also we have not included the data for 2020 to 2023. If we look at that data, the trend will be much worse. And also for the environmental health risk, we already got environmental data. For example, we have estimated air pollution data, drought data, flood data. So we can link that data to the health outcomes. So from our group, we have tried to use the big data to understand the impact of the environmental exposures. For example, this is a global network initiated in 2013 after my graduation. So I collaborated with Professor Antonio Gasparini from London School of Hygiene and Tropical Medicine. At the very beginning, we only have collaborators from about 9 countries, but currently we have involved more than 60 countries, and we have collected mortality, morbidity, birth outcomes from more than 3,000 communities. So we can link this data with environmental data. So this is the first paper to look at the temperature impact on mortality in 12 countries. Very interesting, we can see in all the countries, cold temperature can increase mortality risk, and also hot temperature can increase mortality risk. But the most attractive thing that is in all the countries, the minimum mortality temperature, that is, or we can call it comfortable temperature range, all of them located in the 75 percentiles of the temperature distribution. That means people have ability to adapt to local weather. If you live in Melbourne, your comfortable temperature is 17 degrees, but if you live in Brisbane, the comfortable temperature might be 27 degrees. So that means we can think about how to mitigate climate change and how to adapt to climate change. If we don't have this big data, we can't understand this pattern. Okay, so this is why this is important. And also for the lag effect of the cold. If today is very cold, the impact will not appear today. It will appear 3 days later, and it will last about 2 weeks. This is for cold impact. Okay, and for the hot impact, that is, if today is very hot, a heat wave, today we will have a highly increased risk of mortality, and immediately, and also this risk will last about 2 or 3 days. So we can see cold effect and hot effect are quite different. So we need to understand how to mitigate that effect. And also for the health adaptation for the heat risks, because with technology development and with economic development, people can try to mitigate the impact of the heat. So we need to understand if there is any change or not. So we collected 7 countries' data with a very long time series of mortality. So to understand if the heat impact have changed or not. So in general, we can say the first one is Australia. In 2006 and 1993, the heat effects are still similar. That means there is no change. But if we look at Japan, Spain, and the US, we can say currently the impact of the heat has mitigated a lot. So that means the Australian government still needs to put a lot of effort to mitigate the impact of the heat waves. Okay. And also because we have many countries and many community data, so we can understand which factors can affect the vulnerability to heat and cold. So the left one, that is, that is for the contributors for the heat impact. We can say, population density, and the people, the population older than 65 and life expectancy, GDP, air pollution can contribute to the impact of air pollution. But for the right, that is cold effect. None of these factors can mitigate or can increase the risk of cold. That means if we wanted to do some work to mitigate the health effect of the cold and hot, so we should consider some of them. But for the cold effect, none of them is effective. We should think about other factors to mitigate the effect. Okay. And also we can use the multi-country data to estimate the grid level temperature and mortality relationship, and then we can combine the grid level mortality rate, population, and we can calculate how many deaths can be attributable to cold temperature and how many deaths can be attributable to hot temperature. So this is the results across the world. So in general, every year there are 5 million deaths can be attributable to cold temperature and hot temperature together. But cold temperature is a large proportion. That is 4.5 million deaths. It belongs to cold temperature. Okay. And also we have air pollution data. We can link the air pollution with mortality data. So we can say for PM2.5 and PM10, for both air pollutants, there is no threshold. That means at any level of PM2.5 and PM10, there is increased risk of mortality. And also we can compare different countries' effect. Very interesting that is the impact of air pollution on Australian people is much higher than Chinese and also than other high polluted countries. So we should think about what is the reason. And also we can link the wildfire-related air pollution and mortality to understand the impact. So in general, total mortality, cardiovascular mortality, and the respiratory mortality are all affected by wildfire-related air pollution. And the impact is immediately after exposure. Okay. And also we can understand which group of hospitalizations are more sensitive to the wildfire smoke. In general, respiratory hospitalizations are more vulnerable than cardiovascular and total hospitalizations. And also we can divide them into different age groups. So for the right panel, that is for age group, in general, elderly and children are more sensitive to wildfire-related PM2.5. Okay. And also we linked the data with cancer mortality. We can look at the impact of the mortality, wildfire PM2.5 on cancer mortality and compare if non-wildfire PM2.5 and wildfire-related PM2.5 are different or not. In general, the pink one, that is the wildfire PM2.5, we can say its risk are higher than non-wildfire PM2.5. And also the wildfire-related PM2.5 can increase half of type of the cancer mortality. And also we can calculate how many global mortality data, how many global mortality can be attributable to daily variation for PM2.5. Currently, there is a GBD study. They only look at the long-term effect, the annual average. But because we have daily data, we can estimate the short-term effect. So in general, across the world, 1 million deaths can be attributable to PM2.5. That means, for the GBD study, they, underestimate the effect of air pollution on human health. And this is a study. We link the global flooding data and our global mortality data. So we can say, for all-cause mortality, cardiovascular mortality, and respiratory mortality, for all of them, there is a lag effect. If today has a flooding, for the mortality risk not appear today, it will appear 2 weeks later. And it will last about 3 weeks or 4 weeks. Okay. And this is tropic cyclone and mortality. We can link all the data together. So in general, the respiratory mortality are more sensitive to tropic cyclone than cardiovascular and total mortality. So that means, during the flooding and the tropic cyclone, we can't only say, the injuries and the accident. We also need to look at the cardiovascular, respiratory, and mental health in the future. And also, we have linked the greenish data and the heat data with preterm birth. So in general, heat wave can increase the risk of preterm birth. And this risk can be mitigated by greenish. So in general, if pregnant women are lived around with the higher density of green space, trees or grasses, there is a low risk of preterm birth from heat waves. And also we use the multi-country data. We can look at if greenness can mitigate the heat-related mortality or not. In general, if people are living with high density of greenness, the risk of mortality from heat wave are lower than those from the lower greenness. And also we have done a series of studies to look at the greenness and the health impact of air pollution. So in general, greenness can mitigate a lot of health outcomes from the air pollution, like mental health, heart disease, birth outcomes, diabetes, blood pressure, lung function, and some others. Another type of study that is environmental scenario analysis. So that means we have a lot of scenarios for the future. If we don't take any action for the climate change, temperature will increase a lot, And in different scenarios, there's different distribution of temperature. So we can link these scenarios for the future projection on the mortality risk. So this is one study. We looked at, in the past 30 years, if there is no climate change, how many deaths can be mitigated, can be avoided. So for the blue line, that is the real context, that is the real scenario. So what we have experienced for the temperature. For the orange one, that is if there is no climate change for the temperature distribution. So we can link this data to our multi-country data. So we can say, in general, if there is no climate change, the the heat-related mortality can be avoided about 1/3. That means, we need to take action to mitigate the heat-related mortality. Of course, in different countries, the effect is a little bit different. And also, we can look at the future heat waves and mortality in different climate scenarios. In general, even from now on, we start to mitigate climate change. There is still an increased risk from heat wave. Okay, in other countries, of course, for some low socioeconomic countries are more affected. And also, we can predict the future temperatures on mortality. So in general, in the future, if there is no mitigation of climate change, the cold-related mortality will be decreased, but the hot-related mortality will be increasing. But the net change is still increased. Okay. And also, this is the future projection for the wildfires. Okay, so we can say there is a loop for the climate change, wildfire, and human health. And also, if we don't take any action to mitigate climate change in the future, the wildfire season and the frequency of wildfires will be more and more, and the season will be longer. Okay, and from our study, we have done a lot of influence. For example, we have worked closely with IPCC to change their policy, and also working with some government to develop the heat wave warning system. And also, the WHO air quality guidelines are mainly from our study, because we have the multi-country data. That is the strongest evidence. And also for the greenness and health, we have collaborated with several city councils to help them to perform the urban design and the green space design. Of course, there are many opportunities in this area. For example, the high-performance computer is developing very quickly. We need to use them, and also we can put the data into the cloud storage and to perform cloud analysis. And also smartphones with GPS, GIS, and also we can measure their health outcomes in real time to develop the real-time warning system. And also the cameras are all over the world, traffic cameras, the cameras outside the elderly community, aging care community, and also shopping centers. We can try to collect the data to convert them into air pollution predictors, and also the big health data, like the regular registered data. We can collect them to do some work. And also for the digital twins, currently developing very quickly, we can use them to do the future projection. Okay. Thank you very much. This is acknowledged by group, and also national collaborators, international collaborators, SMRC, ARC, and Monash University. Okay, thank you very much.
Okay, open for questions. And for the people at the back, there are some seats down the front here. People, it's great to see the room full. You should have given us a bigger room. Need a bigger boat, yeah. But come down and find a seat. Anyone would like to ask a question? Perhaps while they're thinking, can I, and maybe I'll take the microphone so that can be heard. It's on. Okay. I was just interested in your green data, the greenness data, yeah. And it occurred to me that at least some of that might be related to economic status. So how do you control for socioeconomic status when you're looking at these large data sets?
Okay, that's very interesting, very important question, because some of them don't understand the epidemiological study. We collect individual economic data if we have the individual data. If we don't have, we have the community level GDP data, and we should put them into the model to control the economic status in different levels. Yeah. Right.
So that is controlled for.
Yeah, they're already controlled. Yeah.
Excellent, excellent. Question at the back there.
I don't know if that's on.
I think it happens automatically.
Oh, hopefully. Okay, I'm going to talk over the top of you. Hi, Ming.
Hello.
Loved your talk. One of the questions, so I come from an uncertainty background, and I would love to know, particularly with this big data sets, how do you, or can you comment on the availability of knowledge around how data was collected and how you actually accommodate for differences, particularly between countries, in the way that that data was collected and reported?
Yeah, so using mortality as an example, so we have many countries collaborators, and they can collaborate. They can collect the data from their country. Generally, we can collect the daily mortality data in different countries, and then we can link the daily air pollution data, mortality data, and the daily temperature data together. We perform the time series analysis for each city first. We can, using this method, to control, the different countries' background and different cities' background. After control this one, and after we get the effect estimate from different cities, we can perform the second stage meta-analysis or meta-regression. And then we should put some other predictors into the meta-regression. And then we can remove another confounders through this progress.
How do you do that for things like big health data, though, like where there's reporting of diseases or, culture-based methods, where there could be gaps or differences?
In general, for the high-income countries, the system is quite good, so we don't need to worry about that.
Yeah.
We need to worry about the low socioeconomic, countries, because they don't have a very good system. But we can help them to develop in the future. Yeah. Thank you.
Yep, come up to the microphone.
Thank you very much for a fascinating presentation. I have two questions. One is when it comes to policy, and when it goes to, for instance, COP28, when the leaders of the countries are discussing about how they can actually affect, how they can actually use this data to prevent death and mortality and things.
Yeah.
How do you can actually pack this data for their understanding? Because we have this amazing evidence.
Yeah.
But when it comes to policy, how we can do that? And my second question is the difference between low and middle-income countries and high-income countries, and the contribution to this kind of climate change effect. When it comes to the differences and the level of resources they have in hand to tackle that, again, how this data can drive the policy initiatives in those two different contexts to somehow address these adverse effects.
Okay, thank you very much. So in general, during our network, we have collaborators from government, for example, Ministry of Health or Ministry of Education, Ministry of Environment. We have collaborations, and at the very beginning, we usually consult with each other. What do they want from us? And then we can make some specific projects. And also to translate the results to them. Usually we can't show the relative risk to them. We need to calculate how many deaths attributable to air pollution and temperature. And also we still need to calculate the health economic loss. Because that is another project. This is not environmental epidemiology. That is environmental health economic. So I did not include them in these slides. So we can calculate how much money can be lost if we don't take any action for climate change. And then we can give these results to the government and to some health professional and something. Yeah. And also, this is just showing mortality. We also have some data for the ambulance costs, hospital admissions, and the emergency department visits. We can calculate how many the non-fatal diseases, and then provide these results to the hospital system and to the ambulance cost. They can understand what will happen in the future. Thank you.
Okay, I think we need to stop there and move on, but a fabulous talk. Thank you very much. So our next speaker is Fiona Russell, and Fiona is the Director of Child and Adolescent Health Program at the University of Melbourne, Group Leader of the Asia-Pacific Health at the Murdoch Children's Research Institute, and co-chair of the World Society of Pediatric Infectious Disease International Scientific Committee. Fantastic. And Fiona is talking to us about strengthening of North-South, South-South partnerships through regional networks to support evidence-based health policy. Thanks, Fiona.
Thank you very much, Steve. And thank you very much to the organisers for the invitation to come and speak today. I'd also like to pay my respects to the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and to their elders past, present and future. So out of the back of the pandemic, the World Health Assembly passed this new resolution, this was 2 years ago, and to strengthen clinical trials to provide high quality evidence on health interventions to improve research quality and coordination. And so last year, the WHO held the first global forum on clinical trials, in particular how to strengthen the ecosystem around that for low and middle income countries. And so one of the objectives of that meeting was to identify key clinical research networks. And then out of that meeting, it was a Lancet paper summarising the strategy or the potential areas to strengthen that ecosystem. And today I'm going to talk a little bit about some of the work that we've been doing in regional and global coordination, not the continuous financing bit, but that's a key area, and also the clinical trial infrastructure required. And I'm on the tag of this clinical trials strengthening committee for WHO, and we're trying to implement some of their recommendations. So one of the key things is obviously having a clinical trial and the results is absolutely key, but the most important thing really is then to translate that evidence into policy and measure and show evidence of impact. And that's where often things get held up quite a bit, that there might be lovely publications, but it doesn't actually get translated into anything. So a few years ago, a review was done looking at knowledge translation for public health in low and middle income countries, and some of the things they found was how important partnerships were at both the global and local level, but also with researchers and policymakers, and also the need for capacity in research, but also in these knowledge translation strategies. So our work started, or my work really started many years ago in Fiji with partnerships, with a long-standing partnership with Fiji and the Fiji government. So I work in the area of vaccination. So about 17 to 24 years ago, there was a number of new infant vaccines that were coming along, but these were not really designed or affordable for low and middle income countries. So we designed a clinical trial for the pneumococcal conjugate vaccine, which is designed to prevent childhood pneumonia, which is the #1 killer of children globally, particularly in low and middle income countries, to figure out how many doses do you really need. We then published that work, and then we were also asked by the government to look at the burden of disease of not only pneumococcal disease, but also rota and cervical cancer, because those new vaccines were coming along too. And so we did that and published that work too. And so the pneumococcal work then translated into WHO position statement in how to be flexible regarding how many doses do you actually need in a primary series, which is 2 rather than 3. So we advocated with our government to then support Fiji to introduce the vaccines, and they introduced all 3 of them through a cost-sharing arrangement. For the past 8 years, that's been highly sustainable. And Fiji was the first country in the region to introduce, or in the world actually, to introduce all 3 vaccines at the same time. We were then asked by the government to then measure the impact, because Australian government supported initially the funding, the government then had to pay for it. So we had to show evidence of impact, and this was at the time when there was very little data from low and middle income countries. So we measured the impact of all 3 vaccines, we supported the establishment of the Vaccine Preventable Disease Unit, and then we strengthened the surveillance. And out of that surveillance, there were a number of other things that were identified, such as neonatal meningitis being about 6 times higher than that in the UK. And now we've got a NHMRC funded, we've just finished that through COVID, of a clinical trial trying to prevent perinatal infections. Also, when the cervical cancer vaccine came out, there were 3 doses that were recommended, and then 2, and now 1. And so one of the studies that we did also in Fiji was following up women who had 1, 2 or 3 doses of vaccine to see how long the protection actually lasted. And we found very high vaccine effectiveness after a single dose, supporting the WHO new position statement. That work then all went to the Pacific Health Ministers meeting. Fiji tabled that, and cervical cancer was identified as one of the top 3 health priorities for the region. And so then the Asia Development Bank wanted to support the introduction, and UNICEF and WHO said, well, don't just do HPV, but do rotavirus and PCV as well. And so ADB funded that with UNICEF support, and then we talked to Rotary as well, and they coughed up some more money. And so all 9 countries who hadn't had all those vaccines were able to then support the introduction of those vaccines. During that process, we were asked to do the health economic analyses because these countries are quite tiny, Tuvalu, Tonga and Vanuatu and Samoa. We used some of Fiji's disease burden data into these models and showed that for all 4 countries, it was cost effective for all 3 vaccines. However, new vaccine introduction has a very large budget impact, and you can see there how much the budget has to increase for all those 4 countries. So for the blue bar is PCV, and that's how high it has to go after introduction to be able to pay for it once introduced. So even though it's cost effective, it's only partially mitigated by treatment cost savings. So from those partnerships, we then developed a network, and so we developed a Centre for Research Excellence for Pneumococcal Disease Control, where we brought together a multidisciplinary team and all our partners in the region to be able to then support countries with their decision-making and providing the evidence that they need for PCV, pneumococcal conjugate vaccine policy. So we then also really importantly is developing the next generation of researchers, and particularly those in the region who are able to lead the research to be able to answer the questions for their policymakers. Then one of the key things in the immunisation field at the moment is, there's all this wonderful technology coming along. There's a whole plethora of vaccines coming down the track. There's malaria, there's RSV, there's Group E strep in the future too. But how are countries going to optimise all this when there's already a very crowded paediatric schedule? So a lot of the work that we've been doing started, 25 years ago, and the stuff that we pioneered was how many doses, again, do you really need? So out of this CRE, the Thailand hasn't actually introduced pneumococcal conjugate vaccine, even though it's been available for 25 years. So out of this work, the Thai government is now funding a clinical trial with Serum's Institute of India, who's supplying a pneumococcal vaccine, which is much cheaper than the other big pharma vaccines, to figure out whether 2 doses of that Indian vaccine is enough. We're also doing policy work with WHO. They're updating their position statement again on how many doses are really needed, because there's a number of clinical trials that have been undertaken in the region and in Africa and the UK. UK is the first country that has adopted a 2-dose schedule. And so to be able to then guide countries that have a flexibility of how many doses you actually need. And then importantly is the monitoring of impact. In many countries, in lower middle income countries, surveillance is very limited and very challenging. There's not the resources or the human resources to be able to do that, and so we've been looking at carriage in the nose, nasopharynx, and seeing what the role of carriage is. So we're updating those guidelines for WHO. And then really importantly, through this network, I think through in the era of COVID, we were able to see really to advocate, I think, for the need for boosters. So when Omicron was coming, it was really obvious that boosters were needed, but it was needed in this region as well. So with our partners through the CRE, we wrote a piece on how important it was for boosters, and also we wrote a piece on, some of the considerations for vaccinating children in the context of now, children had all been infected, and many countries hadn't even introduced rotavirus vaccine or pneumococcal or HPV vaccine. So where does COVID sit in that space? And so trying to get priorities in terms of understanding that. So now in a lot of the work that we do is really about knowledge translation for immunisation policy and programs. And so we as academics and with WHO and various local institutions and partners support governments and in their region and ministries of health and their National Immunisation Technical Advisory Group committees in putting together evidence. Again, it's sort of triangulating too, where you don't have necessarily the perfect data, but how can you be confident you've got enough data to be able to make a decision about a vaccine without having to wait 5 years for, to set up your surveillance system. So that's using, routinely source data, but in addition, formal research as well. So it depends on the context. So one of the projects that we've got in Laos is supporting them through their Gavi transition, and this is through a learning health systems and health strengthening approach. And we've co-designed this with the Ministry of Health, the local National Immunisation Technical Advisory Group, and WHO and partners. And it's looking at the whole ecosystem from the research through to the the policy and then measuring impact. And we've got many partners from the region, from where I am at MCRI, but also Australia and also the local and regional sort of partners as well. And there's three elements to that. It's the NITAG and using the WHO Global NITAG Network Evidence to Recommendations modules, and that's led by Professor Nigel Crawford, who's our ATAGI chair. And then we have health policy unit strengthening through the local university and the NITAG and in health economics and health technology assessment and advocacy to translate evidence to policy. And then there's the mapping vaccine research needs to be able to then inform the program to make sure that everybody's communicating and that the government's getting what they need from all their resources that are within countries. So out of our CRE and pneumococcal, we had a forum in 2022, our first one for the because we all sort of started during COVID. So we had the first one in 2022. We had a face-to-face with all our partners in the region. And what came out of that was really that, pneumococcal, of course, is very important, but we really need to set up for all vaccines and establish our Asia-Pacific Vaccine Research Network. And so with all the work that we've been doing through MCRI and different partners in the region, for many years we've got extensive established collaborations and we perform vaccinology training and vaccine research training. And in vaccinology, it's all from clinical trials through to surveillance to observational studies and then health economics. So through all that ecosystem, we've put it all together with all our partners and we've developed the Asia Pacific Vaccine Research Network in partnership with the University of Gadjah Mada in Indonesia, which is a WHO training partner organisation. And we've done that through DFAT with the Australian Awards Fellowships. And now WHO has made us a partner with the University of Gadjah Mada for clinical fellowship and research training. And we're the only institution in Australia that has that status with WHO. So we've co-designed this as well with the fellows who come, and they're very senior people, often NITAG members and decision makers in country, and we use a case-based approach and local research examples. So what our fellows have done, what we have done in partnership, we focus on South-South learning to help find solutions to common vaccine policy and immunisation challenges. So again, many of these countries don't have their data, but many of the questions are similar. And so sharing of data and sharing and looking at what's happening in the region, there's a lot of commonality in the questions that are being asked and the research that's required. And also importantly, we've now got a bit of funding to then mentor the next generation to lead policy relevant research too through individual projects over the next few years. So this will also, coming back to the original, the WHO strengthening of clinical trials, it will also help seed the development of vaccine research and clinical trial network to be able to pivot to the next pandemic. So many countries in our region were left to beg for vaccines, which I'm sure many of you know, and low and middle income countries were left to essentially beg and sort of kind of more or less be last in line for vaccines. So it's really trying to get countries ready and upfront with all the research and all the things needed and all the networks to be able to hit the road running, not for their, in peacetime, but also during, health emergencies as well. And we've also set up ongoing professional development through a seminar series. Now at the University of Melbourne, there's the Oceania Institute that was just launched about a month ago or so. And in that, the VC announced the potential for joint PhD programs, which is another really important thing that we can help support other academics and strengthening research in the region. So in summary, really how important it is for us, certainly in the Australian context, to be able to reach out and develop joint PhD programs, I think, with partners in the region, how important it is for continuous financing of research and research training networks and clinical trial platforms. We need to keep them hot all the time rather than this on-off thing, grant to grant and, trying to lose all that expertise in between when you're trying to get your money together. Really important, as for all of us as researchers and also for government and public health, is to adopt learning health systems approach so that, you're just not publishing something. Of course, that's important in a journal, but how important to engage, really important with communities or partners from the beginning to be able to transition. And while there's time for questions, I'm going to just leave you with this slide because it's World Immunisation Week. It's the 50th anniversary of immunisation. And we at the World Society of Paediatric Infectious Diseases put out a call to action for fairer vaccine prices because most countries can't afford these vaccines. And so there's a QR code. If you'd like to support us, we've got all the main players signed up. You can read more and you can hear more too. There's a webinar later in the week. So I'll leave that there so you can scan it and maybe you consider signing and supporting us. Thanks.
Thanks, fantastic. Thank you. All right, we're open for one or two questions. We're a bit backed up now, but maybe I'll just ask one question. I was at a meeting recently in Cape Town and Jeremy Farrar, who's your chief scientist for WHO, thought that the clinical trials we're running were generally too small and we needed bigger clinical trials. Do you want to just comment on that?
Yeah, I will. So essentially, there are many clinical trials being done, but it's the quality that's the problem. And certainly out of COVID and the COVID pandemic, and that's why this came about with WHO, was 95% of the clinical trials that were done for the therapeutic trials that were done during the COVID, 95% of them were junk, essentially. So 95% of people enrolled contributed nothing because they were so poor quality. And so that, obviously really needs to change. So it's the quality of the clinical trials that's the real key.
Great answer, great answer. All right, we might stop there, Fiona. Thank you very much. Our next speaker is Cheryl Carcel. She's the head of the Brain Health Program at the George Institute for Global Health and the Australian and principal investigator for the Centre for Sex, Gender Equity in Health and Medicine. And Cheryl's going to talk to us about addressing sex and gender bias, invisibility and exclusion in health and medical research, policy and practice. Looking forward to it. Thank you.
Thank you to the organizers for the opportunity to speak this afternoon. My disclosures are funded by the NHMRC and World Stroke Organization and receive funding from Bayer. Maybe I'll start with a brief definition. Sex and gender are not interchangeable. We know that sex is defined as biological attributes of humans and animals, including physical features, chromosomes, gene expression hormones, and anatomy, while gender is more complex. It's socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and gender diverse individuals. And then I'd like to begin really the reason why we're doing our sex and gender research at the George Institute. And this is Jane. She emailed the George Institute after she saw a publication that came out 2 years ago. And she said, last night I saw the media release on my local news and had tears in her eyes because she's had a young stroke in 2018. So Jane was 45, female, married with children, and she had sudden difficulty in reading and writing and could not differentiate a fork from a knife. And so she called 000, which is the ambulance here in Australia, and they said to her, you are a tired, stressed out mom, maybe try and take a rest. We could take you to the hospital, but they're pretty busy. And so finally, her symptoms worsened. She had a really bad headache. So she self-admitted to hospital. And when she was in hospital, she was triaged to sort of the hallway because there was an elderly man who needed more immediate attention. And finally, after she was seen, after a few hours in the ED, she was. They told her she had sort of a perimenopausal migraine. And discharged and given an outpatient MRI referral, MRI of the brain. And in the public health setting, this can probably take a couple of weeks. And the final results were that she actually had a stroke. So this was a really big missed opportunity for Jane to receive life-saving treatment. And so this is sort of related to that. So this was the media, this was a publication of the media release that Jane saw. And we looked at differences in pre-hospital management of women and men who've had a stroke by emergency medical services in New South Wales. And so this is also using linked data, linking ambulance service data with all the private and public hospitals in New South Wales of stroke patients between 2005 to 2018. So there were over 200,000 people, nearly half of them were women, And there was no difference in the time that women and men arrived to hospital from calling the ambulance. Women were more likely to call an ambulance. And there was no difference between women and men in being diagnosed as having a stroke in general. However, in those women who were less than 70 and what we call sort of youngish stroke, they were less likely to be assessed as having a stroke. And remember that these are all patients who've eventually been diagnosed as stroke in hospital. And they're more likely to be diagnosed as having a migraine like Jane did, or having an anxiety, hypertension, or just nausea. And they're also more likely to be less likely to be managed as having for a stroke protocol according to New South Wales Ambulance. And so why is this important? It's important because in everyone recognized a stroke by the pre-hospital, in the pre-hospital setting, they're immediately brought to a stroke-ready hospital, and they're given hyperacute stroke treatment, which could mean the difference between, walking out of the hospital upon discharge or being wheeled out in a wheelchair. And there's also some evidence that women might benefit more from acute stroke treatment, which is thrombolysis. So this is even more crucial to diagnose stroke in women. And we think that some of the issues is that this is sort of the message we get, and I think this is great for the general public because having too many symptoms in your head might be difficult to memorize. But we have this, so FAST is if you have a droopy face, if your arm, you can't lift both arms or one arm, if you have problems with your speech, if you're slurred or can't find your words, and it's time to call the ambulance. But in reality, there is a lot more symptoms that women may have in terms of stroke. And, the top sort of 3 or 4 symptoms of women and men are the same, which is really good. But there's also a lot of symptoms in stroke that are under-recognized in women. And this isn't only happening in Australia, it's happening worldwide, it's happening in the US, it's happening in Europe, and I've recently reviewed a paper reporting similar things in Africa. And we know from that example that there's sex and gender inequities, bias, or blindness in research. And it's not just in clinical research or human research, it goes all the way back to cell research, where sex is often unreported. In animal research, where they only use male animals. In human research, where there's underrepresentation of women and people of variations of sex characteristics, trans and gender diverse individuals. When we don't consider sex and gender definitions in our trials, or even if we have this data, we do not report the sex differences in efficacy and safety of these trials. And so this paper was a part of my PhD, and this was really a call to action to the medical community, looking at where are we, this was in 2019, 2020, where are we in terms of sex and gender policies in health research? And it's a busy slide, but this is open access on MJA. But we had a series of recommendations for different stakeholders on how we can improve sex and gender integration in health and medicine in Australia. And so this paper targeted different stakeholders like universities, academic societies, government, funders, journals, and industry. And what that paper was really trying to say is that we need a shift in clinical practice. We need certain interventions such as, the policies, improving education, capacity building, and shifting sort of behavior so that we can have more sex and gender sensitive research. And so thankfully our project was funded by a philanthropist, and this is actually the end of our project. This month is the last month of our project, and it was a collaboration between the George Institute and Australian Human Rights Institute, both of which are based in UNSW. And it was a big team. I'm really proud of this team. We had a lot of people with lived experience, people who are coming from the LGBTQI community, health economists, and people who are Aboriginal and Torres Strait Islanders contributing to this project. And the project was in different phases. The first one was really crucially important, which was mapping out the different stakeholders who are already engaged in sex and gender policy research in health and medicine in Australia. And phase 2 was to build local capacity. How can we help these organizations create their own policies so they might lead their own organizations to integrate sex and gender research? And then phase 3 was a cost-benefit analysis, and I'll talk about each phase briefly. And really, in phase 1, where we mapped current policies, we found there are so many stakeholders already in Australia that are working in their own different silos, working on sex and gender research, when we can all benefit from working together. And we found that there were several barriers, and again, mirrored by the facilitators. There's lack of awareness of the issue. There were problems with sex and gender definitions and fear of sort of addressing the gender aspect of these definitions, lack of education, lack of willingness to disrupt what they already know, what they already feel comfortable of doing. And the facilitators were having champions in this area, so having local leaders. For example, if you are in the funding field, having a leader in that area, and where everybody else will want to follow. Willingness to engage, accountability, and need for acceptance or other facilitators. This is a busy slide, my apologies, but this was phase 2, and we worked with the Association of Australian Medical Research Institutes in democratic drafting process of their policy. And really it was working with members from the ground up of of AMRI, inviting people, and these were not only researchers, these were researchers, there were operational staff, some leaders, some early career people, and this was sort of a 3-workshop process, and in the end we came up with policy recommendations for medical research institutes. And you can see a list there, but what was important was that there was visibility and awareness and critical need for consideration of sex and gender integration. There needs to be a robust mechanism to respond to ongoing change, because these definitions and evidence is very fluid. There needs to be appropriate inclusion of people from different background and increased education efforts. And this is, so the phase 3 was looking at cost-benefit evidence, and our health economist just stepped out of the room. I was going to point to her if you had any questions later, but I will try my best. So this is bringing back to that case I talked about earlier about Jane. And so upon presenting to ambulance in New South Wales, women are less likely to be accurately diagnosed as stroke compared to men when they are sort of younger. And so what is the economic cost of this, or what is the economic benefit of women simply receiving the same level of quality of care that men do? And this is not the optimal level of quality of care, but just the same level as men. And so QALYS is quality adjusted life years, and it's sort of a generic measure of quality and quantity of life. But if you look in the first sentence, you'll see that when women are diagnosed to having a stroke as much as men, that means they will also receive early life-saving treatment. There is, maybe 3 to 4 months of years added to their life, and a cost saving of $16,000 per person over a lifetime horizon. But if you extrapolate it to a national level, there are hundreds of quality of life adjusted life years gained, and a cost saving of over 18 million. And so the conclusion of this is that health gains and cost savings resulting from greater gender equity in stroke care benefit Australian society, not just men, but not just women, but the Australian society as a whole. And our work really is, in conjunction with the statement on sex-gender variations of sex characteristics and sexual orientation in health and medical research by the NHMRC, which is the main funding body in Australia. And I think there is now sort of a critical mass where different stakeholders are now coming together. There's all these different types of approaches on integrating sex and gender into health, into research, and into medicine. And so these are sort of the different groups that have started coming together since we wrote that call to action paper 5 years ago now. And so through those different efforts from different groups, a Center for Sex and Gender Equity in Health and Medicine was launched. And we sort of launched it last week, and there is a QR code there if you want to know more about the center. But really, this is all the different communities coming together to bring together a national effort on integrating sex and gender. And during that launch, we had really good engagement from the community, from government, from researchers, and from the business community. And we had, and one very important aspect of this center is working with people with lived experience. And we had Jen O'Neill talk during our launch, and she was one lady who had 3 heart attacks by the time she was 42. And so I guess in terms of generating knowledge for global health, I would think that a center such as this would sort of, so in that previous panel I was in earlier, they mentioned that you cannot address global health without addressing gender equity. And so this center aims to address that, and we want to ensure that sex and gender are routinely considered in health and medicine, in research, policy, practice, and to improve the outcomes of all Australians. And this center is aiming to conduct high-quality research, importantly facilitate translation of this research into policy and practice. We want to build capacity and communicate and advocate continuously for the integration of sex and gender, and also engage with stakeholders, because I think what Fiona mentioned earlier about co-design is really important when you want buy-in for your projects. And so that's, thank you.
Thank you very much. I'm open for questions.
Thanks for the great presentation. I'm interested in, you mentioned a lot of gender difference in the healthcare for stroke. I'm wondering what contributes to this gender difference? Is there a biologically reason, or is it just because the healthcare system didn't do the right job? Or can you explain more about it? Thank you.
Thanks for that question. I think it's really important, and I don't think it's one difference. I think you are right. It could be biological, but it could also be women and men's different interactions in the healthcare system. It could be implicit bias. It could be also there is lack of data of women because we don't enroll enough women in clinical trials. So it needs to be, I guess, addressed in all these different areas.
Okay, thank you.
One of the things we at NHMRC noted when we were writing that policy was the issue around pregnancy and also very early life, where there are also major gender issues and people not being enrolled in clinical trials, and we don't know what drugs to give pregnant women because they never get enrolled in trials and so on. Do you want to just comment on that?
Thanks, Steve. And I am lucky because that was one of my talks in the previous panel.
Oh,
but
right,
sorry. I agree it's very important to include pregnant and lactating women in clinical trials, because what we're doing now is we're using sort of data that was proven good, proven efficacious for middle-aged women and men, without testing them on pregnant and lactating women. And I think that's a difficult and challenging issue. It has clinical and ethical issues. But the suggestion has been that in clinical trials, we need to have maternal and fetal experts in steering committees. We need to have better monitoring of safety outcomes if we want to be more inclusive of pregnant women.
Yep, thanks. All right, we might stop there. Thank you very much. Okay, our next speaker is Danielle Mazza. Yep, that's right. And Danielle, I'm just looking for your CV. Yep. Chair of General Practice and Head of the NHMRC Centre of Research Excellence in Sexual and Reproductive Health for Women in Primary Care, or SPHERE, at the Monash University. And Danielle will be talking to us about bringing about policy and practice change to ensure access to sexual and reproductive health services for women. Thank you.
Thanks, Steve. My presentation is a little bit different from those that have come before because it's got a little bit more of a local focus, so please bear with me. I'd like to start by acknowledging the people of the Kulin Nations on whose land Monash University operates and pay my respects to traditional owners of the land on which we're all meeting today. I'm going to talk to you a little bit about my mission in research and the centre that I lead called SPHERE, where our aim is about achieving accessible, high-quality, comprehensive women's sexual and reproductive health services in primary care. We're fortunate to have been funded by the NHMRC once and again twice. So we're just embarking on SPHERE 2.0, and I'd also like to acknowledge my collaborators, particularly Kirsten Black, who's in the audience today. So let me tell you what the problem is. What's the issue? Why engage in this area of research? Fertility regulation is really critical for a woman's life trajectory and for her being able to achieve her reproductive goals. And if you think about first age of intercourse in Australia is about 16, the average age of first-time mothers is 32, and the average age of menopause is 51, then people in Australia who plan to have 1 or 2 children typically spend about 5 years pregnant, postpartum, or trying to conceive, and over 30 years trying to avoid a pregnancy. And they're often using a contraceptive method that has a failure rate of about 9% or higher per year, like the combined oral contraceptive pill. So that gives rise to a lot of problems, right? And in Australia, we know that about 40% of pregnancies are unintended. So 1 in 4 women have had an unintended pregnancy in the last 10 years, and 30% of unintended pregnancies in Australia end in abortion. Rural women are about 1.4 times more likely to experience unintended pregnancies, and for younger people, 41% report an unintended first pregnancy. So these are pretty significant numbers, right, and affect many of the women in our lives as well as ourselves, our mothers, our sisters, our aunties, our cousins, our girlfriends, our wives, for those who have wives. And so where are we at with contraceptive service delivery in Australia? And we're not doing very well for a developed country. Long-acting reversible contraception like IUDs and implants are the most effective form of contraception with a failure rate of less than 1%. But our uptake of these methods is shocking. Only about 11% of Australian women are using a LARC as a method of contraception. The international benchmark in developed countries is around 20 to 25%. Sweden is the poster child with a rate of about 31% in 2019, the majority of these are IUDs. So what is it? Why don't we have good uptake of effective forms of contraception? Well, one of the biggest issues is our workforce. So the majority of women seek out their contraceptive care and their abortion care in general practice, in primary care. But unfortunately, my discipline is not well trained in this area. We know that about only 10% of GPs nationally are currently trained or delivering medical abortion, and there's no formal GP trainee training in this area. Implants, we're doing much better. 70 to 80% of GPs nationally deliver implants and put them in, and we know all of our trainees receive training in this area. We've got no idea what's happening in terms of which GPs and how many put in IUDs. But what we do know is even when GPs are trained to put in IUDs, they might commence doing them, but many don't sustain that form of practice. So women are running around trying to find effective forms of contraception, and their local providers don't deliver these services. So as part of our centre, we undertook a randomised trial in general practice to try and increase LARC uptake. And our intervention was pretty basic. We did some online training on effectiveness-based contraceptive counselling, putting IUDs and implants at the forefront of the way you deliver contraceptive counselling, starting with the most effective forms first. And we also provided a rapid access, a referral option to a LARC insertion clinic. And look at the results that we got in terms of LARC uptake. By 4 weeks, women in the intervention group, 19% of them had taken up a LARC. By 6 months, 44%, 12 months, 46%, and at 3 years it was still sustained at 41%. So compare that back to the 11% we talked about. If we give some focus in training and this rapid ability to access LARC insertion clinics to GPs, we'll get more LARC uptake in this country. We followed these women up at the 3-year mark, and we were also able to demonstrate reductions in unintended pregnancy and abortion. So that's a fairly simple kind of intervention. Another fairly simple kind of intervention is to support GPs and primary care practitioners to deliver these services. And another NHMRC project that was funded was our AusCaps network, and you may have heard Jed Carney talk this morning. Our AusCaps network has now been funded for a further 3 years by the federal government of Australia. AusCaps is an online community of practice, a bit like a Facebook group, but a lot more organised. And what it gives GPs and primary care practitioners is the opportunity to get support, get advice from peers and clinical experts, download resources, guides, checklists, patient information, watch webinars, podcasts, access LARC training and medical abortion training online and through other providers. And it's become the kind of go-to page, go-to site for primary care for the delivery of these kinds of services. We're also looking at other ways to ensure access to sexual and reproductive health. Our Orient trial, which is well on its way, we're hoping to get final results by the end of next year, is looking to assess the effectiveness of a nurse-led model of care in general practice for improving women's uptake of LARC and access to medical abortion in rural and regional areas. And we're using AusCaps and other forms of implementation support to ensure that the nurses in these practices are able to deliver these kinds of services. We're also supporting pharmacists to deliver contraceptive counselling and refer on to a contraceptive provider, ensuring that there's no closed doors for access and that women can move through the healthcare system in primary care and receive the forms of contraception that they need. Alliance also will wrap up in 2025. Oops. But one of the, keys to our success, particularly, these are kind of practice changes I've been talking about. One of the keys to our success, I think, in influencing policy has been our ability to actually talk about these issues quite graphically in detail and give politicians and policymakers the figures, right? So 40% of pregnancies in Australia are unintended. 1.4 times more unintended pregnancies in rural women. This map was very influential. We showed it to Greg Hunt, who was the then Health Minister. And if you look at this map, all of the areas in yellow are areas that in 2019 there was not even one GP prescriber of medical abortion and no pharmacist dispensing this medication. The green areas also had no GPs providing these services. And he looked at this and he said, wow, that's a lot of part of Australia that has no GP providing these services. We had put together a coalition of key stakeholders and clinician experts, and we were able to drive our advocacy through this vehicle, bringing together a consensus and engaging with our College of GPs and College of ONGs to really put forward the solutions together. And as a result of, in part, there were others also advocating, Greg Hunt introduced Medicare item numbers for telehealth, sexual and reproductive healthcare consultations in July 2021. So for the first time in Australia, a woman could access a medical abortion remotely via Medicare and get funding to do that. And there are no these telehealth item numbers persist, and there are no restrictions on this. So you can be sitting in rural WA and get a medical abortion from a doctor in Queensland under this system. But we also were able to present through our coalition the evidence to support therapeutic goods administration and PBAC regulatory reform to medical abortion. So up until August of last year, GPs, medical abortion was regulated in a way that was completely different to any other pharmaceutical in the country. So GPs were forced to undertake mandatory training in order to register to prescribe. We can prescribe opioids without mandatory training, but we couldn't prescribe medical abortion. We had to register and then re-register. Individual pharmacists needed to register to dispense, and such was the case that women would have a script for medical abortion, turn up to their pharmacist, but if that registered pharmacist was on sick leave or on maternity leave or on holiday, they couldn't get their medication dispensed. And the prescriptions were restricted to medical practitioners only. But from August of last year, that's all changed. We presented the evidence from our colleagues in Canada who had done away with this mandatory training, who'd allowed all pharmacies to dispense and nurse practitioners, and we had shown to these bodies the rapid increase in the number of providers providing these services. So I'd like to thank my colleagues, my sphere investigators, and all of the partners that we work with, and look forward to continuing our work to increase access to these services around Australia. Thanks.
Thanks very much. Terrific. Open for questions. Anyone like to come forward? I guess I'll start. Implementation is always the most difficult thing. I mean, the research you presented was fantastic, and even the rollout in the areas that you looked at. But are you confident that you're getting implementation across the country?
Yes, so part of the problem that we've got in Australia is we don't have a very good research infrastructure in general practice and primary care. We need
time you did something about that, Danielle.
Yes. So we need more practice-based research networks so we can actually look more clearly. We've got evidence of PBS from PBS data and prescribing that medical abortion is increasing in its availability, but we're not seeing any strong outcomes yet in terms of LARC, and we need more investment from government in training.
Thank you. Any other questions? All right, we might leave it there. Thank you very much. Okay, our next and last speaker is Marion Saville, and she's the Executive Director of the Australian Centre for the Prevention of Cervical Cancer. And Marion will be talking to us from research to implementation and scale up, limiting cervical cancer in the Indo-Pacific. And obviously we heard this morning the wonderful state of cervical cancer work in Australia. So really looking forward to this. Thank you.
So thank you very much for the opportunity to speak to you today, and I too would like to acknowledge the traditional owners on the land of which we are meeting, and pay my respects to elders past and present and any Indigenous people who happen to be joining us today. So sorry, I just haven't got the capacity to move the slides just at the moment, which is, I'm trying to bring us in on time. This is not helping, but no. Is it this? Yeah. Okay, thank you. Can we go back though? Okay. Sorry. So, cervical cancer, as you probably all know, is almost always caused by human papillomavirus. It is a slow-moving virus and a slow-moving and forgiving natural history, which means that with vaccination and screening, we can prevent this disease. And as such, it is a disease of inequity. If you have access to vaccination and cervical screening, you are very, very unlikely to develop this cancer. And you can see the rates there are very high around the world in the low and middle income countries. And it's worse than that. It doesn't only affect mid-aged women, but it affects their children and communities, and creates a large number of maternal orphans around the world with massive knock-on effects. And on the right-hand side there, you can see the impact of cancer on creating maternal orphans dominated by breast and cervical cancer. In the case of cervical cancer, we've got the tools to prevent this. And accordingly, in 2020, in the middle of the pandemic, with attention elsewhere at the World Health Assembly, all member states endorsed this strategy to eliminate cervical cancer as a public health problem, where the target rate is 4 per 100,000 women per year. Australia is presently world standardised at around 6.5 per 1,000 women. We've got our own equity problems. I won't talk about that. It's a disease of inequity within and between countries. And so we are aiming to put countries on the pathway to elimination by the end of the century, 90% of girls vaccinated against HPV by the age of 15. You've heard about dose reduction earlier today. There's really very good evidence now that we only need 1 dose of HPV vaccination, and that is an incredible opportunity, which is to some extent being held back by the reluctance of the big manufacturers to change their labels. We want to see 70% of mid-aged women in the 30 to 49 age group globally screened twice in their lifetime, 10 years apart, with a high-precision test. And what that means is an HPV test or anything that comes along in the future that is as good as better. What that does not mean is cytology, and I am a cytopathologist. I can tell you that is right. And it does not mean visual inspection with acetic acid, which has been going around lower middle income countries, and unfortunately, for a whole range of reasons, is not effective and is very much more resource intensive than people think. And of course, we want to see 90% of people with pre-cancer detected being offered treatment, and also 90% of women who develop this cancer having access to cancer treatment, and most importantly, that we close this gap in access to palliative care. But it's really important that we act now on all fronts. You've heard earlier today about vaccination, and this modelling underpinned the WHO strategy. You'll see there the Daffodil Centre from Sydney, University of Sydney, and Cancer Council were one of 3 global modellers that came up with this. In blue, we could rely on vaccine only. It will take a lot longer. We will do nothing to improve the lot of adult women now, and even young women who are only just older than 15. But if we add in 1 or 2 screens in a lifetime, as you see in the green and the purple, we can save an additional around 15 million lives. So that's the context, the research. There's been a lot of research about the effective ways of screening, and this research was led at the Institute for Medical Research in Papua New Guinea together with colleagues from the Kirby Institute, and we worked with them, and we compared the performance of visual inspection with acetic acid against HPV primary screening. And to cut a very long story short, we showed unequivocally that this is a very effective a very safe and highly acceptable mechanism. And its acceptability really turns on the fact that when you use an HPV test, in other evidence I won't show you today, the sensitivity for the detection of precancer is as good when a woman collects a sample from her own vagina with a swab as when a sample is collected from the cervix by a doctor or a nurse. And that is really important for acceptability. It is also really important in countries like Papua New Guinea for scalability, because you don't need a nurse to deliver a screen. You need a nurse to see a person in whom we detect HPV. And so we were very lucky. I can't believe I left the funders logo off this slide, but we were philanthropically funded by the Minderoo Foundation, don't tell them please, to do this a scale-up experience. So this is now not research, but based on that research I showed you. And here we're aiming to hit those three targets, the 90, 70, 90 targets in the Western Highlands province of Papua New Guinea and in Vanuatu. And each of them have about 40,000 age-eligible women for screening. I'll just talk about the screening pillar here. Our model is self-collection, a point-of-care HPV test, and then treatment with thermocoagulation, as we did in the research. And this is all delivered by nurse midwives, except that the self-collection, of course, doesn't need an interaction with a nurse. We added to this registration. So people in the audience who live in Australia and are age eligible and have a cervix, you will have had a letter from a register. And registers are how we organise cancer screening programs, and we should organise all of our public health programs so that we can track and facilitate the follow-up of screen-positive women and understand the performance of our programs in a way that allows for continuous improvement. We don't send letters using our software that we developed for this sort of setting. We have a very flexible application, and actually having worked with a number of low and middle income countries, we've moved through using SMS for reaching people long before the pandemic, through to now WhatsApp, which is a much more stable point of contact in nearly every LMIC we've been in. So this enables the teams on the ground to follow up people that have had a positive test but have not been treated on the day for a variety of reasons. They're not eligible for treatment or they've left without being treated. And we now, top left, have had formal launches in the Western Highlands province in March last year and in Vanuatu in October last year. There has been unprecedented demand, and I put this down to the fact that when you go into a country that has a high burden of cervix cancer, almost everyone knows somebody who has had this disease, and almost always they're detected late, they don't have access to cancer treatment, and they have very, very poor outcomes, including social stigma and isolation, no pain relief, renal failure, and it is really a very terrible disease in these settings. So although health literacy may not be good, when you offer a way of screening that does not involve a speculum, the demand is such that actually the problem is meeting the demand. And if we go into these communities and try to drum up interest, we find it's quite quick that you become overwhelmed. I'm sure there will come a time when with late adopters we'll have to do more health promotion, or our partners will, but that hasn't quite happened yet. These are the maps we get out of the CanScreen product. In the Western Highlands province is the dark brown one that you see there. And actually, I probably should have updated this, but to date, out of our target, we're trying to reach 30,000 women. We've reached 16,000 women, and 90% of screen positives have been adequately treated. So we're making progress there. And remembering, this isn't like our old screening where we do it every 2, 3 or 5 years, once in a lifetime, possibly twice, affording really good protection. And this is another view that the teams on the ground can get. And in Vanuatu, we've screened 8,000 women, and the team like this map because they use it to plan their outreach from those 2 hubs that you see there. So I'm nearly coming to the end to land this on time. Scale up. I'm very pleased to say that our consortium that you see there is working now, planning to work across the 3 pillars, and in a project we're calling EPIC, Elimination Partnership in the Indo-Pacific for Cervical Cancer. We were very pleased to be awarded one of these partnership grants from the Department of Foreign Affairs and Trade, announced last November on the anniversary of WHO's announcement of the strategy. Briefly, we will work across those 3 pillars, but also health system strengthening, so strengthening laboratory capacity for the diagnosis of cancer and for lab-based PCR testing, the implementation of the registry software, and the policy and modelling support across all pillars, so that once we have done a round of screening, countries can really set about making the economic case for continued investment, which isn't going to be quite so demanding on their budgets as what's happening now, because they only need to do the people becoming age eligible, so the 30-year-olds. We're very excited to be close to contracting on this award, and we're working throughout the Pacific. Tier 4 is just modelling support, but you can see as you go up to Tier 1, these are countries in which we are expecting to do a whole round of screening and put those countries well and truly on the pathway. We hope this work will have broader impact, because cervical cancer is a non-communicable disease with gender impacts that is caused by an infectious agent, which most NCDs aren't, and we want to uplift women's health and communities through doing this. And finally, I'll just acknowledge our country partners who lead so much of what we do and tell us how to improve the support that we give them. And I'll leave you with that quote from Vanuatu. Thank you.
Thanks very much. What a fantastic program. Fantastic example of movement right from biomedical research right out into the community. Really, really good. Questions? Yep.
My name is Shailendra Savleshwar from Sydney Uni. It's fantastic to see this. I've been waiting for this, but it does beg a question. This is a global health summit. You're doing amazing stuff for cervical cancer. What else could you put in these programs that will improve the lives of this woman? Because cervical cancer is one aspect that we can improve by vaccination. But have you thought about linking other things, education, livelihood, microfinance?
I think that's a bit outside of my scope, but I will say that the vaccination programs are delivered with the other vaccine programs, and integration is really important. So the screening is being integrated into ongoing sexual and reproductive health services, and the next stage actually is design a program for women living with HIV who need slightly more intensive screening, and that will be integrated into HIV services. So we are as a team, we're very focused on cervical cancer with various different outputs, but I think for me the key is integrating into the other services. And it is just such a privilege to work on a cancer that can be eliminated, that we have the technical tools, and that we don't need to be seeing women for this every 2, 3 or 5 years. And that means that there's more room for their other needs.
Okay, I think we might stop on this story. It's a fantastic story. Thank you very much. But I'd also like to thank all the other speakers. It's really been a terrific session. So can we give a great round of applause to all our speakers? Thank you.